2022. And you can see that the mortality rates are highest in these high-income countries. Also, in our setting, you can see that the rates of mortality is quite high. Zoning into the Global Care in 2022 South African statistics, you can see on the pie charts, it demonstrates the top 5 cancers amongst females in South Africa for the year 2022. And uterine cancer ranks 5th out of the 5 cancers, but it's second amongst the gynae cancers. And on the far side, you can see that divergent bar graph looking at the incidence and mortality of endometrial cancer. And you can appreciate that there's still work we need to do to curb the mortality. In terms of the risk factors, so the risk factors are broadly divided into 3 categories based on the underlying pathogenesis of developing endometrial cancer. So firstly being unopposed estrogen, second hereditary, and last by association. So in terms of unopposed estrogen, so it's both endogenous and exogenous causes. In endogenous causes, so early menarche, late menopause, also a prolonged estrogen window, chronic ovulation, infertility, estrogen secreting tumors. And we know the effects of estrogen on the endometrium, that it causes endometrial proliferation of the endometrial cells, putting the patient at risk of hyperplasia, and there's a risk of malignant changes, especially with the atypical endometrial hyperplasia, up to 29% to developing cancer. And then obesity carries a significant risk into developing endometrial cancer, and the pathogenesis is by conversion, peripheral conversion of androgens to estrogen. And then in terms of the exogenous causes, it's unopposed estrogen, especially in hormonal replacement therapy, where you don't have the protective effects of progesterone, as well as the use of tamoxifen in breast cancer. So we know that it has an antagonistic effect on the breast, but an agonistic estrogen effect on the uterus, causing hyperplasia. So the table just shows the various risk factors and the relative risks associated with each risk factor. And we can appreciate that hyperplasia and obesity, as well as Lynch syndrome, carry a significant risk into the development of endometrial cancer. In terms of hereditary, so Lynch syndrome, as well as other HNPCC-associated syndrome, as well as Cowden syndrome, carry significant risks into development of endometrial cancer. So Lynch syndrome is a hereditary cancer susceptibility syndrome. It's characterized by mutations in the mismatch repair gene, and it carries a significant lifetime risk of endometrial cancer of about 40 to 60%. Not only endometrial cancer, but as well as colon cancer. And then Cowden syndrome, it was the first time hearing about it, preparing for this presentation. It's an inherited autosomal dominant disorder with mutations in the P10 gene, and it carries a lifetime risk of about 13 to 30% for endometrial cancer. And then other factors by association. So these factors don't directly cause endometrial hyperplasia, but they've been found to have a high incidence in patients with endometrial cancer. And this includes metabolic syndrome like hypertension, diabetes, hypothyroidism as well, BRCA carriers, first degree relative with endometrial cancer, and previous pelvic radiation. So in terms of the protective factors, so the protective factors have been described in literature. So firstly, in terms of the obstetric protective factors, multiparity, pregnancy, and breastfeeding have been found to reduce the risk of endometrial cancer. Multiparity has been shown to decrease the risk of endometrial cancer by 80% with a subsequent further reduction of 10% for every subsequent child. And the mechanism is the reduction of exposure to estrogen, the suppression of endometrial mitotic activity, as well as endometrial shedding during delivery. In terms of contraception, so long-term use of contraception over 10 years of both combined oral as well as progesterone-only contraception and intrauterine devices have been shown to reduce the risk of endometrial cancer with protective effects lasting up to 10 years by decreasing the number of ovulation. And in addition, the IUDs induces a chronic cytotoxic inflammatory response. In terms of hormonal replacement therapy, so both estrogen and progesterone containing hormonal replacement therapy is protective in terms of developing of endometrial cancer, and its benefits also persist up to 20 years. And then lastly, exercise in terms of lifestyle modification with obesity as well as metabolic syndrome. So who do we screen? So screening, so the population has been divided into three: the general population, the population that is at increased risk, and then the high risk population. So screening in the general population is not recommended because there is no test that has been shown to be effective in terms of screening of the general population. The risk of endometrial cancer without the risk factors is quite low, 2 to 3%. So universal screening is not recommended. In terms of the population at increased risk, these are women with risk factors for endometrial cancer, and their relative risk depends on the individual risk factors. Screening is not recommended in this population. However, it is advisable to educate the patient on the individual risk of developing cancer, lifestyle modification, as well as the protective factors. And in terms of the high-risk population, so again, we go back to Lynch syndrome and the other inherited disorder. They have a high risk of lifetime risk of developing endometrial cancer, ranging from 32 to 60%. So in this population, screening is recommended. So there aren't really randomized control trials that have governed screening strategies in this population. So it's largely based on expert opinion. And really, screening involves patient education and an annual pelvic exam, transvaginal ultrasound, and an endometrial biopsy. And this begins from about 30 to 35 years, and a prophylactic hysterectomy and bilateral salpingo oophorectomy post-childbearing. In terms of the histological subtypes, so endometrial cancer was traditionally classified as type 2 and type 1 endometrial cancer, which is the estrogen-dependent cancers, and then type 2, which is the estrogen-independent cancers. So starting with type 1 endometrial cancer, so it occurs in 75 to 85% of cases. Endometrioid adenocarcinoma is the most common subtype, accounting for about 80% of cases. The risk factor here is unopposed estrogen, with the precursor lesion being endometrial hyperplasia. So they have well-differentiated tumors. They present in early-stage disease, and the prognosis is relatively good. These are the mutations that have been identified. So the P10 tumor suppressor gene in 30 to 80% of cases, the microsatellite instability in 20% of cases, and the P53 in up to 50% of cases. In terms of the type 2 endometrial cancer, it occurs in 15% of cases. The most common subtype is serous carcinoma, and P53 mutation is the commonly occurring up to 90% of these cases. It occurs in the much older women, so 60 to 70 years, and it arises in the background of endometrial atrophy. So these cancers are poorly differentiated and are generally associated with a poorer prognosis. The woman presents with more advanced as well as metastatic disease. This is just a table summarizing the various characteristics of type 1, type 2 cancers, and you think this is relatively easy. So why the change? Why did we migrate to more of the molecular classification? So when they looked at the emerging literature, they found that there were a few drawbacks in terms of the classification system of type 1 and type 2 cancer. Mainly that firstly, they found that these were not distinct entities, and there was a lot of overlap between the two tumors as well as the molecular characteristics of the tumor. The second finding was that there was a lot of intertumoral diversity, and we see that in the endometrioid carcinoma, like the low-grade type 1 and 2 have a distinct prognosis and a molecular profile and pattern of disease as opposed to grade 3. And also there was a large inter-observer variability amongst the pathologists in terms of analyzing the histo specimens, especially in high-risk disease, and that will compromise our patient care, prognosis, as well as management. So the latest classification system is from FIGO. It's the fifth edition WHO classification of tumors for female genital tumors. It separates the endometrial cancers into endometrioid carcinoma, which is further subclassified into low-grade and high-grade, and then the aggressive subtypes, the serous clear cell, the dedifferentiated and undifferentiated carcinomas, the mixed, and the other subtypes, and carcinosarcoma. So I'll just briefly run through the next few slides. It's like histology 101. So first, it's endometrioid carcinoma. It accounts for 80% of endometrial cancer, and this resembles the normal endometrial glands. So it's divided into low grade, so that's grade 1 and 2. So that's solid components of either less than 5% and 5 to 50%, and then high grade where there's solid tumor more than 50%. And then any nuclear atypical for that grade increases the tumor grade by 1. The other histological subtypes include squamous differentiation in 50 to 25%, 2% in the aviloglandular, and 1% in secretory. So low-grade tumors have good prognosis, and high-grade tumors, the prognosis depends largely on the molecular profiling. The mucinous carcinoma accounts for 5% of endometrial cancer. The tumor comprises of 50% of cells with intracytoplasmic mucin. It's classified as a variant of low-grade ECC, and it has a relatively good prognosis. So serous carcinoma accounts for 10% of endometrial cancer. It occurs in postmenopausal women in the background of endometrial atrophy with or without a polyp. The histology, it has highly atypical cells, and it's often mixed with other subtypes. It's associated with lymphovascular space invasion and deep myometrial invasion. They're highly aggressive and have a poor prognosis, and they have a high propensity to spread intra-abdominally. The clear cell carcinoma is less than 5%. It occurs in older women. Clear cell carcinoma also has poor prognosis. Next is the undifferentiated or dedifferentiated carcinoma. This is the least well understood of the major histological subtypes. It's rare and highly aggressive. So the dedifferentiated tumors are low-grade endometrioid carcinoma with distinct aggressive subtypes, and the undifferentiated tumors, they have no evidence of either glandular or squamous differentiation. So carcinosarcoma, previously known as triple MT, it accounts for less than 5% of endometrial carcinoma. It's got high-grade sarcoma as well as high-grade carcinoma. And the biggest factor affecting prognosis is the size of the tumor, and has an overall 5-year survival rate of 40 to 50%. In terms of molecular profiling, so this represents a paradigm shift from the morphological classification of endometrial cancer to a more molecular classification with distinct prognosis. It has shown to improve prognosis, and it also lacks inter-observer variability. So the Cancer Genome Atlas in 2013 identified 4 molecular subgroups. So they had a pool of 307 endometrial cancers and 66 serous endometrial cancers, and they did whole genome sequencing on these tumors, and they identified a few molecular subgroups 4. So it's the pole mutation, the microsatellite instability, the high somatic number alterations, as well as the copy number low group. So this is just a graphical presentation, just to simplify it. So the pole mute group is the ultra mutated group. These have an excellent prognosis. The MSI and the CN low have an intermediate prognosis, and the somatic number high, the serous-like carcinomas, they have a high copy number burden, and they have a poor prognosis. So the biggest issue with this classification system was that it was not applicable to a clinical setting. The cost of doing these tests were quite expensive. So there were various groups that sort of came up with more clinically applicable systems. So the most validated system was by Promise, and they applied a few immunohistochemistry, and they came up with the four. So it's pole mutes, the mismatch repair deficients, the non-specific molecular profiling group, as well as the P53 abnormal group. So this is relatively busy, and I don't want to confuse everyone. But really the take-home message, and maybe Dr. Maharaj will elaborate at the end. But the pole mute group, this is a group of tumors who have an excellent prognosis. So they have a 5-year survival rate of over 95%. And if you look at the cohorts of the tumors in this TCGA category. So a majority of those tumors were endometrioid low-grade tumors. And you can see in the bright pink, those were endometrioid high-grade tumors that had pole mutated. So although we would have classified them as high risk, because of the molecular profile, we can now de-escalate and classify them as low risk because they are pole mutated. So that's one of the benefits of molecular profiling, that it has allowed us to escalate or de-escalate treatments according to the molecular profile group. And then the extreme end, the P53 abnormal group, this is the group that has the poorest prognosis. They are very aggressive tumors. Even the treatment is quite aggressive. Then there's a hand of tumors that are labeled as multiple classifiers. So these are tumors, it's less than 5%, but they have multiple classifiers. So they're either pole mute plus P53, and you always take the favorable molecular profile. So there will be pole mute. And if it's mismatch repair with P53, you take the lower or the more favorable prognosis or molecular profile. This is an even more confusing table. I took this from the latest ESMO guideline, which now try to incorporate both the histological grade as well as the molecular profile, and it separated patients into various risk strategies. So either low risk, intermediate risk, and high intermediate risk and high risk tumors. And they've used this classification to further guide the management of the patient in terms of the upfront management as well as adjuvant therapy and lymph node assessment. And we'll go through that now. So going back to the clinical presentation, so these, in terms of how these patients would present, now that we know a little bit about the tumor, they would present with vaginal bleeding discharge in 90% of patients, and 90% of pelvic pressure discomfort, hematuria and pyometria, if there's cervical stenosis, and less than 5% of these patients will be asymptomatic. In terms of the examination, they'll have constitutional symptoms like obesity, hypertension, and other features of metabolic syndrome. And in terms of sign, you need to do a full gynae examination, looking at all the structures, including a full a bimanual examination, assessing the uterine size, mobility, the adnexa, the parametria, and the cul-de-sac. And you need to do a metastatic examination to look for lymph nodes, and then palpate for ascites and evidence of hepatic or lintel mates. In terms of the investigations, so upfront would be a transvaginal ultrasound, and here an ET of more than 5 millimeters, or a polypoid endometrial mass with a fluid collection must be evaluated, and the biopsy modality of choice is the PEPAL. It has a sampling success rate of 95% and a diagnostic accuracy of between 90 to 98%. The indications for doing a hysteroscopy plus DDNC would be in cervical stenosis, patients who's intolerant to the PEPAL, recurrent bleeding after a negative biopsy, as well as an inadequate specimen. In terms of the pre-treatment evaluation, so it's the baseline bloods and the metastatic workup. In terms of imaging, basic imaging, chest X-ray and an ultrasound abdomen, and if you do have access to a CT staging, plus or minus an MRI, especially if there's uncertainty about cervical extension, and as well as others like a pap smear. So this is images of, so firstly, it's a transvaginal ultrasound looking at the longitudinal view of the uterus. You can see that there's a thickened endometrium with fluid within the endometrial cavity. And you can also appreciate in the picture with increased vascular charge, showing myometrial invasion extending into the serosa, and then lastly an MRI showing myometrial invasion and a little bit of cervical extension. In terms of the prognostic variables, so these are all the variables that affects the diagnosis, the prognosis, the management of the patients. So they've been divided into the histopathological, molecular, the clinical, and the blood-based biomarkers, and I'll just speak about the histological. And those have been classified according to the subtypes, the FIGO stage, the histological stage, lymphovascular space invasion, and the depth of myometrial invasion. So we've already spoken about the histological types, as well as the tumor grading. So in the interest of time, I'll go through that. So in terms of lymph node status, so lymph node metastases impacts on staging. So we now know that it upstages to 3. C, it impacts on the treatments. It predicts disease progression, recurrence, as well as survival rates. So the risk of lymph node mets ranges between 5 to 50%, and this depends on the grade, the depth of myometrial invasion, as well as the histological subtype. It's the most important prognostic factor in early stage disease, and it has a 6-fold higher likelihood of recurrent disease if you have positive lymph nodes, so para-aortic versus pelvic lymph nodes. In terms of myometrial invasion, it refers to the distance between the tumor myometrial junction to the serosa. It's divided into 3 main categories. So no myometrial invasion, less than 50%, and more than 50%. So the non-invasive or superficially invasive tumors have an 80 to 90% 5-year survival rate, whereas in the deeply invasive tumors, it drops to 60%. And with increasing depth of invasion, there's an increased likelihood of extrauterine spread as well as recurrence. So in patients with no myometrial invasion, pelvic lymph node mets is about 1%, but those who have outer third myometrial invasion have a 25% of pelvic lymph nodes and 17% of para-aortic lymph nodes mets. In terms of the lymphovascular space invasion, so it looks at the invasion of tumor cells into the lymphatic and the vascular system at the tumor front. It's a strong predictor of lymphatic dissemination and lymphatic recurrence, and it has an overall incidence of 15% in early disease, and this increases with tumor grade and depth of myometrial invasion. It's divided into focal as well as substantial lymphovascular space invasion, where focal is limited to less than 4 vessels and substantial is 4 or more positive vessels. and it must be distinguished from its mimickers, mouth, as well as retraction artifacts. Moving on to the other prognostic variables, so cervical stroma invasion refers to invasion of the cervical stroma at the level of or deeper than a benign endocervical crypt, and it's associated with increased risk of extrauterine disease, lymph node mets, as well as recurrence, and it occurs in a higher grade, larger, and more deeply invasive tumor. In terms of the adnexal involvement, just the one thing I wanted to speak about was the ovarian involvement. And it's important here to distinguish between metastatic ovarian disease versus synchronous tumors. So endometrial plus ovarian cancer. So if it's a high-grade lesion and you have ovarian involvement, it's metastatic disease. But if it's low-grade lesion with an ovarian involvement, you manage those as two independent tumors. In terms of peritoneal cytology, it's associated with poor prognosis if there are other poor prognostic features and if there's extrauterine disease. And intraperitoneal mets is highly correlated with lymph node mets. In terms of age, younger women have a better prognosis compared to older women, and older women have a higher incidence of unfavorable histological subtypes and grade 3 endometrial tumors. And increasing age is associated with disease recurrence. In terms of the hormone receptor status, receptor positive tumors have a longer survival time, with progesterone receptor levels being stronger predictor of survival. This is just a summary of everything I've said into one slide. So it's looking at the various prognostic variables that I've spoken about, and the risk and route of metastatic spread. In terms of the staging of endometrial cancer, so it's staged according to the 2023 FIGO staging. Stage 1 is disease confined to the uterine corpus, where 1A disease is limited to the endometrium, or there's non-aggressive histological types. 1A is when there's non-aggressive histological types limited to the endometrium polyp or endometrium. 1A2 is when you have non-aggressive histological types with less than 50% of myometrial involvement or focal lymphovascular space invasion. 1A3 is when you have low-grade endometrioid carcinoma limited to the uterus and ovary. 1B is non-aggressive histological types with invasion of more than 50% of the endometrium with no or focal lymphovascular space invasion. And C is when you have aggressive histological subtypes limited to the polyp or confined to the endometrium. In terms of stage 2, it's invasion of the cervical stroma or the substantial lymphovascular space invasion or aggressive histological subtypes with myometrial invasion. So 2A is when you have invasion of cervical stroma with non-aggressive histological subtype. B is substantial lymphovascular invasion with non-aggressive subtypes, and C is aggressive subtypes with myometrial involvement. Stage 3 is when you have local or regional spread of the tumor of any histological subtype, where 3A is invasion of the uterine serosa, adnexa, or both. 3B is metastasis or direct spread to the vagina and or parameter or pelvic peritoneum. And then 3C looks at metastasis into the lymph nodes, and that's been separated into pelvic and para-aortic lymph nodes and further subdivided into micro and macro metastasis. Stage 4 is spread to the bladder mucosa and or intestinal mucosa, as well as distant metastasis. So 4A is invasion of the bladder mucosa with and or intestinal or bowel mucosa. 4B is abdominal peritoneal mets beyond the pelvis, and 4C is when you have distant mets. In terms of lymph node dissection, so systemic pelvic and para-aortic lymphadenectomy is not indicated in all patients. And this was based on two trials, the Aztec trial as well as the Italian trial, where they looked at lymph node dissection in early stage disease, so either pelvic or systemic lymph node dissection with node positivity of 9 to 13%. In terms of the Aztec trial, they had no exclusion criteria, but the Italian study excluded those following tumor grading. So the limitation that was associated with these two trials is that they had excluded these low risk cases. So we are unsure of the therapeutic benefits of lymph node dissection in low risk disease. Also, the lymph node dissection was limited to the pelvis, and we know that there is a risk of para-aortic lymph node metastases. So limiting it to the pelvis, we don't know the therapeutic benefits. And the study findings did not target the post-operative treatment, so we cannot compare whether it was beneficial to do this. So the indications for lymph node dissection is evidence of extrauterine disease if they have high-grade endometrial carcinoma, if they have any aggressive histological subtype, and more than 50% myometrial invasion. And if the above absence, bilateral pelvic lymph adenectomy is indicated if the tumor size is more than 2 centimeters, or para-aortic lymph adenectomy is para-aortic lymph adenectomy if positive pelvic lymph nodes. In terms of the sentinel lymph node biopsies, the sentinel lymph node is the first lymph node or site of metastasis, and it's indicated in early stage disease, and it has been described as an alternative to lymph node examination in high intermediate risk or high risk groups. And this was based on a FIRES trial which looked at sentinel lymph node biopsy to lymph adenectomy for endometrial cancer staging. It was a multi-center prospective cohort study. And what they found, the pros of sentinel lymph node biopsy is that it reduced the morbidity following complete lymphadenectomy, and the biggest complication being lymphedema, and the cons being that it missed 3% of node positive patients. In terms of the management of endometrial cancer by stage, stage 1A and 1B disease, you've got two options: primary surgery, which includes peritoneal cytology, TAH plus BSO. There's also room for primary radiation therapy, and I'll go through that in the next few slides. Lymph node evaluation is not indicated because of the low risk of nodal mets. In terms of post-operatively, there's no indication for adjuvant therapy, so these patients you can observe. And in terms of molecular profiling, they are low-risk ECC, so adjuvant therapy is not recommended. In terms of stage 1C, in terms of primary surgery, it's peritoneal cytology, TAH, BSO, omentectomy, and appendectomy. In primary radiation, the modality would be external beam radiation. In terms of lymph node assessments, in higher grade endometrial carcinoma, you can do sentinel lymph node evaluation, but with the other aggressive histological subtypes, you need a full lymph node dissection. Post-operatively, there's room for adjuvant vaginal vault brachytherapy. So what are the surgical options in stage 1 disease? So you can either do a vaginal hysterectomy, and it's indicated in the obese patients, those with poor medical status, or extensive uterovaginal prolapse. In terms of the tumor characteristics, it's low-grade tumors, so endometrioid grade 1 to 2, or less than 50% myometrial invasion, and a tumor size less than 2. Laparoscopy is a surgical option. The pros would be decreased hospital stay and morbidity, a short as well as an earlier return to work and post-operative recovery. The cons is a longer operating time and a risk of conversion to laparotomy. So various studies have compared laparotomy versus laparoscopy, and they have found that there's no difference in terms of the lymph node counts, the blood loss, recurrence, as well as intra-op complications. So they were comparable in terms of the surgical side, but we'll see in the next study that there's been a difference in terms of patient's experience. So emerging field is robotic surgery. There's limited data in oncology studies, but it's said to offer the same benefits as laparoscopy. In addition, it has a shorter operative time. It's suitable for the morbidly obese patients. And the cons is being cost and then the insufficient data for oncology outcomes. So this was a study that looked at patient outcomes and experiences following either robotic, laparoscopic, and open surgery for endometrial cancer. It was published in the International Journal of Gynecology Cancer. So it was a cross-sectional study, looked at 182 patients in January 2020 with confirmed endometrial cancer, and it classified patients under robotic, laparoscopic, and open surgery, and it compared the patient-reported outcomes as well as the experience of these patients. And the conclusions from the study is that in terms of the robotic surgery, patients reported better satisfaction, quality of life, and sexual function. Laparoscopic surgery, they reported improved mobility and daily activities, and with open surgery, enhanced emotional well-being. In terms of radiation in stage 1 disease, so primary radiation is only indicated for patients who are unsuitable for surgery, either because they're elderly, obese, or they have severe medical comorbidity, where the operative risk exceeds 10 to 15% of the uterine risk of recurrence. So in stage 1 disease, intracavitary radiation has shown to achieve better local control in terms of vaginal recurrence, and external beam radiation is indicated in grade 3 tumors, those with deep myometrial invasion and with lymph nodes metastasis. In terms of adjuvant therapy in stage 1 disease, so in stage 1 and stage 1, there's an option of observation as well as radiation in 1C. Observation is indicated for low-risk lesions, so 1A and 1B, and these patients generally have an excellent prognosis and usually require no further post-operative treatments, and they have a 100% disease-free survival rate was recorded in a GOG study of 71 out of 92 patients. In terms of vaginal vault radiation, so it uses high dose rates brachytherapy, and it's indicated in high risk early disease endometrial cancer. The pros is that it's well tolerated with low risk of severe or chronic complications, and it achieves good local control. There has been a documented risk of relapse of 4.5 compared to 3.5 amongst the high-risk patients who received external radiotherapy in POTEC-1 study. So POTEC-1 study looked at the surgery and post-operative radiotherapy versus surgery alone for patients with stage 1 endometrial carcinoma. So this was a multi-center randomized control trial. So the findings of the POTEC-1, it showed that a post-operative radiotherapy reduces local regional recurrence. And you can see in the radiotherapy group, the number of patients who had local regional relapse was 11 versus the control group. This was the surgery alone, which was about 40, but they showed no impacts on overall survival, but an increase treatment-related morbidity. So in summary, it's not indicated in patients who are less than 60 with grade 2 tumors and with superficial invasion. In terms of the PORTEC-2 study, it looked at vaginal brachytherapy versus pelvic external beam radiotherapy for patients with endometrial cancer in the high-risk intermediate group. So it looked at those patients with stage 1B to 2A fecal disease. And the key findings of this study was that vaginal brachytherapy is effective with preventing local regional recurrence. With fewer GI side effects, and vaginal brachytherapy is the treatment of choice for these high intermediate risk tumors. This is just a diagram breaking down everything I've said in a simplified version, and I'm going to run because of time. So this looks at the surgical options for stage 1 disease, and then the adjuvant treatment options for stage 1 disease based on either patients are low risk or high risk. Am I going back? In terms of stage 2 disease, so in terms of stage 2 disease, there's a lack of randomized prospective studies that actually formulate a definitive treatment plan. So managing stage 2 disease is sometimes challenging, especially with pre-op assessments of cervical disease. Treatments of stage 2 cancer must include lymph node examination. So because of the high risk of lymph node metastasis, up to 36%. So in terms of management approaches, so two have been described: either the traditional approach, which is combined radiation and surgery, so it's external pelvic and intracavitary radiation, followed by an extrafacial hysterectomy and BSO, versus the primary surgery approach followed by radiation, which is a staging lap with pelvic and para-aortic lymphadenectomy. So looking at the pros of the traditional approach, the pros is that it's suitable for patients that are medically inoperable at the time. The cons is that it has severe GI as well as uro complications. And in terms of primary surgery followed by radiation, the pros is that it allows accurate surgical staging and pathological information, and it's an alternative for patients where use of radiation is of conflict, and it yields excellent results. The cons is that it can be an unsuitable approach depending on the patient's profile, and there's no improvements in the outcomes with less radical surgery. In terms of adjuvant therapy in stage 2 disease, so it's either vaginal vault radiation or external beam radiation. In terms of external pelvic radiation, so it's delivery of 4.5 to 5,040 in 180 centigrade daily fractions up to 5 to 6 weeks with a boosted dose. And the radiation field is the upper half of the vagina, the lower border of L4, and 1 centimeter lateral to the margins of the bony pelvis. It's indicated in extrauterine pelvic disease in the absence of extrapelvic disease. The overall complication rate is between 25 to 40%, and only 1.5 to 3% with serious complications. And some of the side effects are GI as well as urinary, so cramps, diarrhea, bleeding, proctitis, hematuria, cystitis, and fistula. So in terms of the evidence in adjuvant therapy, so 2 trials I've quoted: the Aztec EN5 trial, which looked at external beam radiation in patients with intermediate to high risk of recurrence. They showed it has no effect on overall survival, and then the PORTEC-2 study showed a 5-year survival rate was not different between these patients. The surgery group, which was 85%, and the post-operative pelvic radiation group, which was 81%. This was further confirmed by Koch. So this is a summary of stage 2 disease in terms of the adjuvant therapy. So it's summarized exactly what I've said. So I'll move to stage 3. In terms of stage 3 disease, so consideration, treatments must be individualized. The operative evaluation and treatment must be considered because these patients are high risk for lymph node as well as intraperitoneal mets. So in terms of surgery, the aim is to determine the extent of the disease and to eradicate all macroscopic disease, and it includes peritoneal washings, lymph node lymphadenectomy, so both periaortic and pelvic, removal of any suspicious lesions within the peritoneal cavity, omentectomy, peritoneal biopsies, TAH and BSO. And post-operative therapy is tailored based on the extent of disease. In terms of stage 4 disease, considerations include, so treatment is individualized, and it's a combination of surgery, radiation, and systemic hormonal therapy or chemotherapy. And the aims of treatment here is to achieve local disease control and for palliative relief of symptoms. And surgical options are cytoreductive surgery as well as pelvic exenteration. In terms of adjuvant therapy, so it's extended field radiation with the entire pelvis, common iliacs, and para-aortic included in the radiation field. And the indication is for histologically proven para-aortic node metastases. The outcome of these patients, 5-year survival rates of 47 to 43% in surgically confirmed isolated para-aortic lymph nodes. In terms of the adjuvant therapy, so whole abdomen radiation is indicated for patients with stage 3 or 4 disease. It can be considered in patients with serous or carcinosarcoma because they have high risk of abdominal spread. And this was a study I found preparing for this presentation that looked at whole abdominal radiotherapy versus combination of chemotherapy with doxorubicin and cisplatin in advanced endometrial carcinoma. It was a COG study. And what they found was that there was a significant advantage of chemotherapy on 5-year survival, and patients who received chemotherapy had improvements of about 13% in 2-year progression-free survival, so 50 versus 46%, with an 11% improvement in overall 2-year survival rate compared to patients treated with just whole beam radiation. In terms of chemotherapy, it's a standard treatment of choice in advanced stage disease. So the 2 studies supporting this, firstly was the PORTEX study, which looked at adjuvant chemoradiotherapy versus radiotherapy alone in women with advanced endometrial cancer. And it showed that adjuvant chemotherapy given either during or after radiotherapy had, for high-risk patients, although it did not improve the 5-year survival rates, it did increase the failure-free survival rates. And women should be counseled when they are treated with adjuvant chemotherapy, as well as this was a COG study. It was a randomized trial which looked at advanced endometrial carcinoma of surgery and volume-directed radiation, and followed by cisplatin and doxorubicin with or without paclitaxel. And they found that the side effects were more pronounced in the 3 regimen with recurrence-free survival. And at 36 months, there was no difference between the 2 arms. In terms of recurrence, it develops in a quarter of patients, and over 50% occur in 2 years and 3 quarters within 3 years. And the distribution occurs, recurrence depends primarily on the treatments. So vaginal recurrence has a better prognosis versus pelvic versus distant mets. And common sites include the lungs, the abdominal lymph nodes, liver, brain, and bone. And in terms of symptomatology, so 34% of patients are asymptomatic, and those with local recurrence will present with bleeding and pelvic pain. In pulmonary may still present with hemoptysis, that's the brain, seizures, ascites, and jaundice in the abdomen. In terms of treatment, so it's divided into three, either surgical, radiation, or hormonal. In terms of surgery, the option is radical pelvic resection with survival rates of 0 to 26%. Complications would be neuropathy and ureteral obstruction and a fistula. In terms of radiation, so is indicated in local or regional recurrence. It's a combination of ERT followed by brachytherapy with survival rates between 24 to 45%, and factors that improve survival include low-risk tumors if recurrence occurs 1 year post-treatment in young patients and those with vaginal disease. There's an option of hormonal therapy in well-differentiated tumors, so progesterone therapy, and if it's contraindicated, tamoxifen, and failed response, you start chemotherapy. So chemotherapy has response rates of about 38 to 76%, with a survival time of 12%. And the response is not affected by previous or current progesterone therapy, interval grade, as well as disease-free interval. I'm going to skip through this. In terms of follow-up and surveillance, the interval is every 3 to 4 months for the first 2 years and every 6 months thereafter. And at follow-up, it's a full history and examination. And the objectives of follow-up is to provide information, psychological support to reassure these patients, educate them of adverse effects of treatments, and diagnose recurrence early. And counseling of these patients is ongoing. You continue with life modification and then imaging annually. So chest X-ray and CT only if they symptomatic. To go through it. So in terms of fertility sparing treatment, it's individualized and it's managed by a specialized multidisciplinary team. So there are various factors we need to consider in terms of which patients we offer fertility sparing treatments to. So patient-related factors that we need to consider is age, just like the normal population. So advancing age is related to adverse pregnancy outcomes in terms of maternal and neonatal outcomes. The weight of the patient, so we know it has a negative effect on fertility, conception, as well as pregnancy outcomes. Patients with PCOS and metabolic syndrome, and then those with Lynch syndrome, these patients have a high risk of recurrence and persistence. So we should be counseling these patients, and you must always check what was really if the patient desires fertility regularly. In terms of the tumor-related factors, so it's indicated for low-risk endometrial carcinoma or stage grade 1, stage 1 BCCs without endometrial invasion. In terms of the workup of these patients, so it's the basic ovarian reserve, so anti-Mullerian hormone or the antral follicle count in the day 2 to 5 FSH, and you do a basic clinical and radiological staging and an adequate biopsy, which is a hysteroscopy and a DDNC using the GRASP technique. In terms of the treatments of these women, it's progesterone-based therapy, so it's either hydroxyprogesterone acetate or migestrol acetate, as well as the Mirena. There's an option of GnRH analogs, either used as monotherapy or in combination with the progesterones and aromatase inhibitors, as well as hysteroscopic resection. So these are the various drug doses. I'll skip through that. In terms of the duration of treatments, it's 6 to 12 months of therapy. If there's no response, radical surgery. In terms of surveillance, you do a DDNC or hysteroscopy biopsy every 3 to 6 months, and if it's successful, it will be 3 to 6 months follow-up until pregnancy or definitive surgery. So partial responders at 6 months, you can give them additional 3 to 6 months of treatments, and if they have no response at 6 months, you counsel for a hysterectomy. So determinants of success would be 2 complete response endometrial biopsies over 3 months minimum interval, and HRT can be considered to shorten the time of conception and reduce relapse and disease progression. So how do you manage patients with an incidental finding of endometrial carcinoma post-TAH for another reason? I think this will be the last slide. So the principles would be a discussion and referral to an oncologist with the MDT. We need to risk classify these patients and evaluate for residual or metastatic disease. And treatment options would include observation in the low-risk group or stage 1A, either surgical restaging or adjuvant therapy. In terms of hormonal replacement therapy in endometrial cancer, so ovarian preservation as well as estrogen replacement therapy is common in endometrial cancer, as 25% of these women are premenopausal and 5% are less than 40 years of age. So the premenopausal women have a 23% higher likelihood of synchronous ovarian cancer, and the risk of malignancy is less than 1% in normal ovaries. So the concern with the use of HRT is the excess estrogen exposure, but studies have shown safety post-CAH and VSO and low recurrence in the low-risk group. So the recommendation is to consider prognostic factors before you initiate HRT. And other options would include topical estrogen, progesterones, or other non-hormonal agents. In conclusion, endometrial carcinoma is a common gynae malignancy. It has a relatively good prognosis when detected earlier. So we need to have a high index of suspicion in those patients who are at high risk. Studies have shown that the histopathological as well as the molecular classification has allowed better risk stratification and management of women with endometrial carcinoma, and MDT is always recommended. Thank you.
Thank you. As you can see, it's quite an extensive and well-researched topic. There's lots of areas to cover, and we decided to focus obviously on the basic treatments and your adjuvants, as well as there's a lot of new stuff going around. So we've chosen molecular profiling. Hopefully during the year, we're able to get you targeted hormonal therapies. I'll call Zonke back to present after she kills me. Are there any questions? We have time for one or two from the audience if anybody has any. Yes, Dr. Valashia.
Summarize which patients can and can offer them vaginal.
So yes, you can offer them vaginal hysterectomy. However, the concern always is, are you able to remove the ovaries? Because your BSO is an integral part of your surgery. So maybe an LABH, where you can do the infundibulopelvic pelvics laparoscopically and then followed by vaginal hysterectomy, because we find that patients have vaginal hysterectomy with the ovaries left behind, and we have to go look for the ovaries afterwards, which is a bit difficult. The patients that you would be able to do here, and I'm happy for you to, is usually your early stage 1As, grade 1 tumors, usually endometrial. It's even a 45-year-old patient with a grade 1 endometrial tumor, and there's no extra uterine disease. That is a patient I'm happy, because there's most likely to be an estrogen-driven tumor. They don't qualify for lymph node dissection. So that would be a patient that, but you're welcome to discuss all cases with us, and then we can sort of direct you if we are happy for you to go on here. Dr. Shangata is not allowed to ask questions. She's supposed to answer them. Okay.
Let me zoom in. I don't remember saying.
One in three.
These are back to my sources. 183 is low-grade endometrial carcinoma is limited to the uterus and ovary.
And then stage 3 one.
Oh, no.
So what's the difference? That's what Dr. Shandazi wants to know.
Oh, they can do that. Come on.
So hard question Dr. Shandazi is asking. It's depending on your histological subtype. He's not even paying attention. So it's depending on your histological type. So if it's a non-aggressive histological or molecular subtype that's confined to the ovary, that is of stage 1. If it's anything other than it's stage 3. So usually P53, if it involves the ovary, it would be a stage 3. So this staging here is a 2023 classification, which is basically molecular classification. So only if you have that can you use the staging. Otherwise, you'll use your traditional stage. Yes, doesn't it?
He have any local experience in managing some complications?
We do. There's a few patients who are considered unfit for surgery or radiation or chemo, based on their medical comorbidities. And we have given them high-dose progesterone, and we've had fairly good responses because they are usually highly ER/PR positive. Recently, they have been more trained to be using tamoxifen, especially in the patients with cardiac diseases, so that to decrease water retention, so they've been using tamoxifen, and they have been getting good response with that as well. In the private sector, they use a lot of tamoxifen to manage.
This
Yes.
tamoxifen is confusing me. Huh?
Yeah, it confuses me too.
It was cited as a spectrum for endometrial.
Yeah.
Last thing used to treat endometrial.
Yeah, I asked the same thing recently at one of our MDTs because they use it for the patients with high ER positivity to block the receptors because they cannot tolerate progesterones. And apparently it's effective, but they can't give me any evidence I've asked for. So I've been looking and trying to figure that one out. But for our purposes, we are still happy with progesterone, high dose. Usually start them off with 100 milligrams daily, moving to 200 daily. Hey, if there are no further questions, then thank you, everybody. Have a good weekend. Thank you, Donkey. We didn't sleep.
Bye.